Hello, this is Elena Coucher. I will be lecturing over chapters 10 and 11, Nursing Management of the High-Risk Pregnancy. So these are some of the risks that we will assess for in the client. We're going to look at biophysical risk. We're going to look at factors that originate within the mother or fetus that affect the functioning or development of either one. We'll look at psychosocial risk, socio-demographic risk, and environmental factors. One of the things that we like to look at is, when we're going to get a health history on them, we need to know, do they have any, how's their nutrition? What about maternal collagen diseases? Gestational hypertension. We're going to look for if they have hypertension because they're an older mother. Those are just some of the things that we look at. And a lot of these conditions that high-risk mothers can be affected with will create in a uterine environment that increases the fetal risk of IUGR, which is intrauterine growth restriction. So biophysical risk, we look at genetic disorders, defective genes, transmissible inherited disorders, chromosomal anomalies, multiple pregnancies, large gestational age, ABO incompatibility. We look at nutritional and general health status overall. We'll look at any medical or obstetric-related illnesses, poorly controlled diabetes. We discussed this in the classroom yesterday. And we discussed about how that gestational diabetes and pregestational diabetes can set the woman up for some risk factors associated with the fetus and herself along the way. We look at hypertensive disorders as well. Some of the psychosocial risks that we're looking at, we look at disturbed interpersonal relationships. Are they in an abusive relationship? Do they face some emotional distress? Emotional distress does not come just from an abusive relationship. I'm talking about, what about their socioeconomic status? Is it emotional distress on them to know that they are pregnant and they might not have the financial resources to take care of themselves and a baby after the birth? What about unsafe cultural practices, substance abuse, smoking, caffeine, alcohol, drugs? The socio-demographic risk, we look at the low income. Low income leads to inadequate financial resources for food and prenatal care, poor general health, lack of prenatal care, which is a financial burden, is a primary risk factor for not seeking prenatal care. The adolescent, they are at risk of more complications. They have a 60% higher mortality rate. They have complications related to anemia, preeclampsia, prolonged labor, cephalopelvic disproportion. There are social implications that are long-lasting. They might not go back to school to get their education after they deliver. So they're at risk of only achieving a lower income throughout their lifetime. They're going to have increased dependence on government support systems in order to survive and take care of their newborns and growing children. Mature mothers, we have to look at their medical history. I always think about, here we are, I'm 40-something years old at this point in time, and, I already have all my children, but there are many women that wait. They wait until they're in their 30s. They wait until they're in their late 30s. If you've heard the thing that 30 is the new 20, they want to get through getting their career established. They want to buy a house. They want to travel. And then all of a sudden, that biological clock starts ticking a little bit faster. And so here they reach their late 30s. They have a little hard time conceiving. And by the time that they do, we already have some of the older aging risk factors that are going on. So we're having to look at them and, if they have chronic hypertension, any other chronic diseases, what about diabetes? They're at risk for prolonged labor. They're also at risk of having to have a cesarean birth, placenta previa, placental abruption, and death. The fetus may be a low birth weight, or they could be macrosomia. I mean, either way, it can go either way with these moms. Chromosomal abnormalities are also a real risk for them, congenital malformations, and neonatal death. Ethnicity is another risk factor that we look at. It in itself is not a major risk, whether you're African American or you're Caucasian or you're Chinese or you're Hispanic. But African Americans have the highest rate of prematurity and low birth weight, as well as infant mortality. Non-Caucasian are more than 3 times likely to die of pregnancy-related causes. So ethnicity is not, like I said, it is not associated, it's not the major risk, but it's maybe a lower socioeconomic status, maybe cultural preferences and cultural differences that prevent them from seeking out prenatal care until, things are going south. Environmental risk factors. Hey, you got to think about the workplace, and we think of nursing, and we don't ever imagine. Oh, I mean, we're in the workplace, we're in in the hospital, but we are exposed to diseases on a daily basis. And if you happen to work on maybe 10A, which is our oncology unit, then you put yourself at risk, and you're unable probably to do a lot of your jobs that need to be done. You have to get people to give your chemotherapy medications, and there are some medications that we actually give on the med-surg floors that's why it's important we know our medications that are unsafe for pregnant women to become in contact with. So we have to look at risk factors. Are they working with chemicals? Are they working with certain gases? Radiation? What if she works in construction? That's an environmental risk factor. We also look at infection, drugs, and any other pollutants. Psychological considerations. Label of a high-risk pregnancy, it may result in an increased sense of vulnerability, stress related to the diagnosis, ambivalence regarding the pregnancy, inability to accomplish a task of parenthood, and fearful for well-being. Family history of any genetic problems needs to be assessed. Nutritional history, high BMI, low BMI, substance abuse. Also just know that moms may not be willing to share their use of illegal and legal teratogenic substances. And that increased sense of vulnerability, I like to speak to that just for a second. I can put myself back into a place before our family had a high risk pregnancy, and I put myself in that place and think, why in the world? You just take care of yourself. You just do what's necessary to get through that pregnancy. Why would you have vulnerability? Why would you feel this way? And that, y'all, I took care of high risk patients, but I never put it into quite the perspective and take it to a personal level until we experienced in our family, and my daughter was a high risk pregnancy. And it's not just increased vulnerability on the mother. She does feel that way. She doesn't know how to progress through the pregnancy because you just don't know what the next day is going to hold. You're just unsure of things, and I can totally relate to that as a family member, because I think we all kind of took on that persona of we feel very vulnerable in this high risk pregnancy. It was totally unexpected, and we even kind of joked about it a little bit about how we would have expected it to be with my other daughter and not this one. So you think about your moms when you are in a clinical setting and you're taking care of your high-risk patients. I want you to kind of empathize with them, feel that sense of vulnerability that they are feeling, so that you can actually minister to them and be able to help them through that time. Now, in a previous lecture, we talked a little bit about daily fetal movement counts and what this actually means. Y'all, this is a very simple, very valuable method to evaluate the condition of our fetus. So we talked about it. We know that we want our moms to assess their babies, and especially when they're high risk. This is very important that they do so. They can do once a day for 60 minutes, 2 to 3 times a daily. We're hoping and expecting at least 10 movements in a 12-hour period. We need to be aware that sometimes the fetus has their sleep-wake cycles. So if she's not getting activity and she has suspicion, then we need to listen to that. We need to evaluate that. Might encourage her to eat a really high carbohydrate food and drink something, get baby awake, and do those fetal movement counts again. In assessing fetal movements, it's important to remember that they are usually not present again during that fetal sleep cycle. They may be reduced temporarily if the woman is taking a depressant medication, drinking alcohol, or smoking a cigarette. Movements do not decrease as a woman nears term. Obesity decreases perception of fetal movements and consequently the ability of the mother to count them. So those are some things that you need to remember when you are instructing your high-risk client to be assessing her own fetal counts. Now let's talk about biophysical assessments. Let's look at ultrasound. Let's think indications for use. Fetal heart rate activity. We want to look at gestational age, fetal growth, fetal anatomy, fetal genetic disorders, placental position and function, and in adjunct to other invasive tests. So if we're looking at fetal well-being, the main role is counseling and support and educating a woman. We can do a blood flow analysis with ultrasound. We're looking at a non-invasive way to study the blood flow. It's very, very useful in maternal hypertension, diabetes, IUGR, multiple fetuses, and preterm labor. It measures the velocity of the blood flow via ultrasound. It's just a visual of the placenta and the fetus. It's an excellent tool. Let's see, also amniotic fluid volume, lack or too much. We might review that via ultrasound. The BPP, or the biophysical profile, done in the late second and third trimester, is used to determine also fetal well-being. And we'll do a modified physical profile that combines other assessments of fetal well-being with a non-stress test. Again, nursing row, counseling, education regarding the procedure. Going back up to that Doppler blood flow analysis, it's reported in a systolic-diastolic SD ratio. Elevation after 30 weeks indicates an IUGR and uteroplacental insufficiency. Abnormalities are also associated with chromosome abnormalities. Nicotine exposure can also increase that SD ratio. The biophysical profile uses the real-time ultrasound. It allows assessment of various parameters of fetal well-being. Their fetus responds to central hypoxia by decreasing their movement. Think about what hypoxia does. Do you want to do a lot of moving around? They're going to decrease their movement. They're going to have decreased muscle tone. They're going to have that decreased breathing movements that they're doing, those practicing movements. There's going to be fetal heart rate changes and decreased variability, and they're going to have some decelerations. And I wish I could show you on a little monitor strip right now. But on a monitor strip, you're going to have an area where the fetal heart rate is, and when you see that variability and it's going along there and it's showing those beats, and then you'll see a deceleration, that's where that heart rate takes a dip and then it'll come back up. We don't want to see those. We'll talk a little bit more as we get further. You can find this chart in your textbook. You're looking at scores from 0 all the way up to 10, 10 being a good normal low risk for chronic asphyxia. A 0 to 2, we're going to strongly suspect that this baby is in distress. They might extend testing time to 120 minutes. If the score is persistent, they're going to deliver regardless of gestational age. So that's what we're looking at. You can look through this and you can see the management, how we score, and what we would do from that score. MRI has kind of sprung up and become a big thing, but again, this is I'll just say not again. It's good. You can see fetal structure and growth. It's good because you can get a good clear picture of the placenta, the position, the density. If there's gestational trophoblastic disease, you can get a good representation of the quantity of amniotic fluid, maternal structures. It's a good one to do. However, there's a big however there. There's two things to think about. The big challenge is for moms staying still for 20 to 60 minutes during the MRI, and the fetus is going to be moving. You can't tell a fetus to be still, and also getting insurance to pay. So I don't know that we use MRI very often. I'm sure with some high-risk pregnancies, some really extensive ones, we probably will go to the insurance company and beat their door down so that we can get MRIs for moms, but it's a hard one for insurance companies to pay for. Biochemical assessment. This is where we're going to start looking at amniocentesis. Amniocentesis is an invasive procedure. We're going to get some amniotic fluid. We're going to use an ultrasound-guided visualization. They insert the needle into the uterus, and they extract probably about 20 mils of the and don't hold me to that. I'm not testing you over the amount they extract. But they're going to extract amniotic fluid for assessment. Now it is not a procedure that does not have complications, because it does. It is invasive. There is a risk of hemorrhage, fetal maternal hemorrhage, infection, preterm labor. They could have abruption, damage to intestines or bladder, and amniotic fluid embolism. Why are we going to do it though? I mean, it's because we're going to look at some genetic concerns that we may have: fetal maturity, fetal hemolytic disease. Usually, if it's going to be done in the second trimester, then we're going to look at chromosomal abnormalities. Maybe we have to evaluate the fetal condition with Rh-ISO immunization. We might have to diagnose intrauterine infections, and then we might have to investigate amniotic fluid volume when the maternal serum AFP is elevated. Indications for the third trimester, we might have to look at fetal lung maturity, via analysis of the lecithin-sphingomyelin ratios, the LS ratio, and presence of meconium that's going to indicate fetal stress. Here's what you need to do. This is your task as a nurse. I need you to have your patient empty their bladder. I need you to get a 20-minute electronic fetal monitor strip. We want to look at the fetal well-being. What are we looking for? Are we looking for variability on there? Obtain and record maternal vital signs. Administer RhoGAM if the woman is Rh negative. Assess maternal vital signs and fetal heart rate every 15 minutes for an hour. We also have to observe the puncture site for bleeding or drainage. What are we going to teach our patient? We want them to rest after returning home. We need them to report any fever. We need them to report any leaking amniotic fluid or vaginal bleeding, contractions. They're going to cramp for a little while after the procedure, but if cramping continues or they note that they're having some contractions, they need to let us know. And any changes in fetal activity. Does the fetus have rights? Amniocentesis, percutaneous blood sampling, and chorionic villus sampling are prenatal tests used to diagnose fetal defects in pregnancy. The tests are risky. They are invasive, so the risk is to the mother and the fetus. So induced abortion is linked to these exams. The issue of fetal rights is a key ethical concern in prenatal testing for fetal defects. And I find this slide to be a little confusing. When not this slide, but the fetal rights part. Because we think about, and I'm not asking for anybody's view or take on abortion, but we, on one hand, we say that, they're not we, but some people say that the fetus is nothing before delivery, and that there's been the talk of late term abortions, that a woman could possibly decide up until the day before she delivers that she does not want this child, and she could have a late term abortion, essentially killing the fetus before it's delivered. So the issue of fetal rights is kind of, I mean, we're doing late term abortions, but then we're looking at tests to determine if there's some problems going on with the fetus, or and that puts the mom and the fetus at more risk. But yet, is there fetal rights for them? Do they get a so-called say in this? So just something to think about. The fetal complications associated with amniocentesis: death, hemorrhage, infection, injury from the needle. The risk may be minimized by using ultrasound to direct the procedure. Chorionic villus sampling is preferred for genetic studies. It's an earlier diagnosis with rapid results. It's usually performed earlier, 10 to 13 weeks. They'll take a small tissue specimen from the fetal portion of the placenta, and then it's done usually cervically or transabdominally. There is also a possibility of fetal maternal hemorrhage. So women who are Rh negative need to receive immunoglobulin after CVS as well. What they're looking for is chromosomal disorders, enzyme deficiencies, fetal gender determination, identify sex-linked disorders such as hemophilia, sickle cell anemia, and Tay-Sachs. The chorionic villi, if you'll remember from previous lectures, those are those finger-like projections that cover the embryo and anchor it to the uterine lining before the placenta is even developed. What are the complications for this procedure? They could have some mild vaginal bleeding and cramping, spontaneous abortion, limb abnormalities if done before 10 weeks, rupture of membranes, fetal maternal hemorrhage. Rh negative moms also need the immunoglobulin, and chorioamnitis. What are you going to do? I need you to have your patient drink increased amounts of water to fill the bladder. Amniocentesis, we empty the bladder. CVS, we fill the bladder. Administer RhoGAM if indicated. Assess the fetal heart rate. Have the patient to watch for and report fever, cramping, and vaginal bleeding. And do not engage in strenuous activity for the next 48 hours. Percutaneous umbilical blood sampling, or PUBS, or chordocentesis. It's a direct access to fetal circulation, usually within the second and third trimester. It allows for rapid chromosomal analysis. It's used for sampling, and it can be even used for fetal blood transfusions, which is pretty cool. They're going to insert the needle directly into the fetal umbilical vessel under ultrasound guidance. In many centers, it's been replaced by placental biopsy, which they consider a safer alternative. Why are we going to do it? Karyotyping of malformed fetuses, prenatal diagnosis of inherited blood disorders, detection of fetal infection, determination of fetal acid-base status with IUGR, assessment and treatment of isoimmunization and thrombocytopenia. They can also administer medications and transfuse the fetus. But then it does have potential complications. Leakage of blood from the puncture site, cord laceration, cord hematomas, transient fetal bradycardia, infection, thromboembolism in umbilical cord, preterm labor, infection, and premature rupture of membranes. We have to monitor our mom's vital signs and fetal heart rate during the procedure. Afterwards, closely monitor the mother and the fetus for any changes. We're gonna have a repeat ultrasound is usually done within an hour after the procedure to rule out bleeding or hematoma. Discharge teaching, report signs of infection, report increase in contractions, and monitor the fetal activity with kick counts. So let's talk about some maternal assays. Alpha-fetoprotein or maternal serum alpha-fetoprotein. These maternal serum levels are screened for neural tube defects, NTDs. 80 to 85% of open neural tube defects and abdominal wall defects can be detected early. And so this blood test is recommended for all pregnant women. If it is abnormal, they're going to follow up procedures that may be indicated, along with maybe obtaining a more detailed family history of any NTDs, repeat the MSAFP screening. Maybe they're going to go for a level 2 or higher level 2 ultrasound or possible amniocentesis. There's also multiple marker screens. These detect chromosomal abnormalities, identify increased risk for trisomy 21. We're going to do a Coombs test to check for Rh incompatibility. It detects other antibodies for incompatibility with maternal antigens. Now, the quad screen is a blood test that's usually done in the second trimester. That's that multiple marker, and it can do identify possible Down syndrome. But here's the thing: there are a lot of false positives with this. I don't know the exact data on that, but and I probably should have got it before I decided to report it within a lecture. But there are a lot of false positives. That women end up having to have upper level ultrasounds to rule out if there's any problems with the fetus. Cell-free DNA in maternal blood. That's a new screening message for a non-invasive prenatal genetic test. Or diagnosis. It'll check fetal Rh status, gender, and paternally transmitted single gene disorders. It works by amplifying the cell-free DNA. I think this test is good. I think all insurance companies need to pay for it. Because I feel like it's a fantastic one for moms to have done. I think if you're high risk, that a lot of insurance companies will pay for it because it will identify a few other things before you have to go into some of the non-invasives or into some of the invasives. Excuse me. So what about electronic fetal monitoring? What is that going to do? It's going to look at the intrauterine environment to find out if it's supportive to the fetus. We have non-stress test, which does fetal activity determination. It's very widely used. And then we have vibroacoustic stimulation. Indications for use when we're looking at a mom with diabetes, hypertension, IUGR, multiple gestation, oligohydramnios, intrahepatic cholecystasis, renal disease, decreased fetal movement, previous fetal death, post-term pregnancy, or systemic lupus. Usually performed in the third trimester, it evaluates adequate fetal oxygenation. We're looking at uteroplacental insufficiency that can result in fetal hypoxia, decreased CO, arterial blood pressure and blood flow to the brain and heart, and decreased variability in the heart rate. The non-stress test, this is used most to determine fetal well-being. A normal fetal heart rate should increase with fetal movement if the CNS is intact. What's going to blunt it? Hypoxia, acidosis, drugs, what's mama taking, such as analgesics, barbiturates, beta blockers. What about fetal sleep patterns? That could do it as well. And then there's also some congenital anomalies. If a healthy fetus has an intact CNS, 90% of gross body movements will produce accelerations with them. The advantages: it's performed as an outpatient. There's no known contraindications. It may produce false positive for non-reactivity due to a fetal sleep cycle, chronic tobacco use, medications, and fetal immaturity. So let's look at what you, the nurse, are going to do when you're taking care of the patient who's undergoing a non-stress test. You want to place her in a reclining chair. You want to put her in a semi-Fowler position. Attach an external fetal monitor, Doppler transducer for the fetal heart rate, a tocodynometer for the uterine contractions. Give the patient a marker and ask her to punch the button when the baby moves. This is if this is the facility that has this. This is what your book might have. This is what other, and again, I want to talk to you about this. I'm only giving you what are some standards that we have, but there could be other things in place that facilities utilize versus giving the patient a marker and asking her to punch the button when the baby moves. Observe tracing, we want to look at fetal accelerations or decelerations in response to the movements, and we'll do that over 20 to 30 minutes. What do we want to look for? 2 or more accelerations of 15 beats a minute lasting for 15 seconds or over a 20-minute period. We will consider reactive and by all accounts considered very normal. We'll see a normal baseline rate and we'll see moderate variability. If the test doesn't meet criteria over 40 minutes, it's considered non-reactive. So further testing may be indicated at that point in time. We're going to look at contraction stress test or on the biophysical profile. A non-reactive test occurs even when non-reactive test occurs when even after repeat the heart rate does not accelerate. Let me repeat that. The test is considered non-reactive even after repeat the heart rate does not accelerate during fetal movement. I think I added an extra word in there. I want to talk to you about equivocal also. What would you think an equivocal test would show? Think about it, the equal sign. The equal sign is saying it's equal on both sides. So it's neither non-reactive nor reactive. Do you think we just need to let that go? No. We're going to have to repeat that test because we need to either know if it's reactive or we need to know if it's non-reactive. It could be that the baby is sleeping and it needs to be woke up. Does mom smoke? Look at what's going on within her. Vibroacoustic stimulation, fetal acoustic stimulation test that evaluates fetal heart rate along with the NST. It monitors the infant for 5 to 10 minutes. We'll obtain a baseline. If the baseline pattern is non-reactive, we're going to do an activated sound for 3 seconds on the maternal abdomen over the fetal head, and then we'll monitor additional 5 minutes. Reactive is you're going to have immediate sustained increased variability in heart rate accelerations. May repeat at 1 minute intervals up to 3 times if not reactive. And if not reactive, then we're going to have to do a further evaluation. The contraction stress test procedure is either going to be nipple stimulated contraction test or oxytocin stimulated contraction test. We're going to interpret that. We're going to look and provide some warning of fetal compromise earlier than the NST. Contractions decrease uterine blood flow and placental perfusion. So contractions should not produce late decelerations in a healthy fetal placental unit. If the fetus is compromised, contractions may produce hypoxia in the fetus and late decelerations will be noted. So CST provides warning of what the fetal compromise might be. It is one of the first electronic tests of fetal well-being. The fetus may be healthy at rest but can't tolerate stress of contractions. So this is why we do such a test. We need to make sure we have a safe delivery of a healthy baby. What do? We observe tracing for 10 to 20 minutes for a fetal heart rate baseline. We look for long-term variability and possible spontaneous contractions. Usually utilize oxytocin or pitocin to produce contractions. You can see what the dosage is here, but I'm not testing you over dosage. I'm just telling you how we would dose that pitocin. The goal is to produce 3 good quality uterine contractions in 10 minutes. It utilizes the same method as beginning as NST. We may ask the patient to perform nipple stimulation to begin contractions. We want to avoid hyperstimulation of the uterus though, and we have to assess the fetal heart rate response to the contractions. A negative CST with no late decelerations of fetal heart rate with 3 contractions in a 10-minute period. A positive test shows repetitive late decelerations. So after 3 contractions, the Pitocin is turned off and the IV is maintained until the contractions stop. So if the test is positive, now this is completely opposite of the ones that we have just talked about. But on this one, if the test is positive, we're looking for evaluation of possible delivery. And then we're going to keep monitoring the fetus until the decision is made. Again, when we're looking at equivocal, I kind of have to stress equivocal when we're thinking about tests, because it's not giving us anything. It's not telling us whether it's a positive. It's not telling us whether it's a negative. So we have to get additional information. We have to keep observing. We may have to keep doing these tests until we can get either that positive or negative, or that reactive or non-reactive. Nursing role and antepartum assessment for risk. We have to educate, we have to support, we need to assist the physician with any procedures, perform the NSTs, the CSTs, and the BVPs, and then we also need to ensure that we have our initial assessment on board. Now we're going to talk about pre-existing conditions. For some women, pregnancy represents significant risk because it is superimposed on a chronic illness, such as diabetes. There's unique maternal and fetal needs that caused by these conditions that must be met in addition to the usual pregnancy-related feelings, needs, and concerns. They're a little challenging to take. It's a two-way street. The course of the disease can complicate the pregnancy, and the course of the pregnancy can complicate the disease for fetus, mother, and the newborn. One can worsen. So what kind of conditions are we looking at? Metabolic disorders, cardiovascular disorders, respiratory, GI, integumentary, central nervous, autoimmune, and substance abuse. Diabetes is one of the most common high-risk problems associated with pregnancy. So let's talk about diabetes. It is the most common endocrine disorder associated with the pregnancy. Pregnancy is complicated by diabetes, is considered high risk. Diabetes can be successfully managed, though, with a multidisciplinary approach, and that includes the patient being on board. Key to optimal outcome is strict maternal glucose control. How difficult as a nurse do you think that might be for the client? Pathogenesis. Diabetes, despite advances in care, the woman whose pregnancy is complicated by diabetes may still have poor outcomes. Pregnancy complicated by diabetes, again, considered high risk. Diabetes can be successfully managed, and we have to give her the tools for good glycemic control. So we're looking at all these group of metabolic diseases characterized by the hyperglycemia, resulting from defects in insulin secretion or insulin action, or it could be both. I'm not going to go into, what type 1, what type 2 is. What you need to know is that you have the pregestational diabetic, and then you have the gestational diabetic. And those can be complicated by either having to have insulin or not having to have insulin. It could be complicated by out of control blood sugars that cause complications with the fetus. Type 2 is most prevalent. Other specific types can be caused by infection or can be drug-induced. Gestational is any degree of glucose intolerance with the onset or recognition during pregnancy. With type 1 diabetics, human placental lactogen, any of them, any diabetic, we're looking at human placental lactogen. It's an insulin antagonist, but it really plays a big part in a type 1 diabetic. What it does is it creates an atmosphere for requiring higher doses of insulin as the levels of placental lactogen increases. That usually happens in the second and third trimester. During the first trimester, the insulin needs of a woman with type 1 diabetics is usually pretty low. Once a diabetic client enters a second, though, that placental lactogen starts to increase, and it's like think about a little brother or a little sister that picks on you. They're antagonizing you. So that placental lactogen is kind of antagonizing that need for the insulin, and so when that does, they have to have more increased doses of insulin during those later trimesters. Metabolic changes associated with pregnancy. Well, we look at pregestational diabetics. They have a pre-existing disease. Can be complicated by vascular disease, retinopathy, or nephropathy. Type 2, again, is not it's not necessarily in the pregestational diabetic a common one. Type 2 is uncommon at this point in time, unless they happen to be a client, and you can, again, you have to look at your patient as a whole. If you know you have a client who has polycystic ovarian disease, then you know that likely she is already experiencing some type 2 diabetic symptoms. But overall, pregestational diabetes mellitus is probably going to be a type 1 versus a type 2. Almost all of these patients at this point are insulin dependent, of course. Normal pregnancy, you have complex alterations in the maternal glucose metabolism, insulin production, and metabolic homeostasis. As maternal glucose levels rise, fetal glucose levels are on the increase, which in turn results in increased fetal insulin secretion. It's interesting to note, I like this, that lactation uses maternal glucose, so the breastfeeding mother's insulin requirements can remain low during her lactation time. We're still talking about the pregestational diabetic. They definitely need preconception counseling. It's a must. They need strict glycemic control before as well as during the pregnancy, because we want positive patient outcomes. Maternal risk factors for this and complications: macrosomia, a very large baby, over 4,000 grams; hydramnios or polyhydramnios, those are used in conjunction, happens in the third trimester. The cause is really unknown. Ketoacidosis, hyperglycemia, and hypoglycemia. Nausea and vomiting and cravings are typical in early pregnancy, can result which in turn causes some dietary fluctuations. So hypoglycemia is a real possibility. A decrease of insulin is usually essential at this time. They're also at risk for preeclampsia, preterm birth. Maternal mortality is much, much higher in a woman with pre-existing diabetes. The pregestational diabetic, the fetal and neonatal risk, sudden and unexplained stillbirth, congenital malformations, especially during the first of the trimester of the pregnancy, especially in the first 8 weeks in organogenesis. That hyperglycemia during that time is the main cause of diabetes-associated birth defects. Congenital malformations account for about 30 to 50% of all perinatal loss in pregnancies complicated by diabetes. They also have cardiovascular, central nervous system, and skeletal problems. Some other problems that cause significant neonatal morbidity because of macrosomia, hypoglycemia. The neonate is at risk for it. The neonate is also at risk for hyperbilirubinemia. There is also at risk of birth injuries: brachial plexus palsy, facial nerve injury, humerus or clavicle fractures, and cephalahematomas. We have to evaluate these patients. We need to get a good history on them. We need to do a good thorough interview, physical exam. We're going to do labs. We want to get their baseline renal function. We need to check their A1C. We want it to be below 6. If they're a type 1 diabetic, you probably not. If they have uncontrolled blood sugars, you're probably not going to see A1C below 6. Probably need to get endocrinologist in on her case as well. They need a lot more frequent monitoring. We encourage diet. We encourage exercise. Insulin therapy, again, is decreased in the first trimester. Very important for a mom to know, especially if she's been taking a lot of insulin throughout before becoming pregnant. Um, so that there's that effect on the woman within the first trimester that keeps that insulin therapy need low. And we don't want her to have some hypoglycemic episodes. Monitor the blood glucose levels, of course. We'll do urine testing every time she comes into the office. Look at the birth date, look at mode of birth. We're going to look at any complications requiring hospitalization. They might have to be regulated and stabilized with insulin. And they're also at risk for preeclampsia. We've got to monitor the fetus as well. Monitor our patients closely. I'm going through intrapartum and postpartum real quickly. We'll talk more about this when we get to the postpartum. We want to monitor for complications, may require cesarean birth. Postpartum, insulin requirements may decrease substantially. Within the first 24 hours post-birth, we're especially going to see that. What happens to our hormone levels? Boom, bottom out, drop. So what do we know about placental lactogen? It's an antagonist. It's not there anymore. It can antagonize the insulin, so their insulin needs are going to drop, especially within that first 24 hours. We're going to have to really monitor them in those weeks after pregnancy, days after the pregnancy ends in the hospital, weeks after the pregnancy ends with her primary care, because she's going to have some fluctuations in there. Encourage breastfeeding, because what does that do? It decreases insulin needs. Now let's talk about the gestational diabetic. Again, you still have maternal fetal risk. We screen for gestational diabetes with all of our pregnant clients. That's usually done somewhere between the 24th to the 28th week. I think it's usually preferably somewhere around the 24th week. Now, all physicians' offices are different, so please remember that. Go by what your book says. That's how I would test. Of course, antepartum care is the same with the pregestational diabetic. Diet and exercise. Monitor blood glucose levels. Insulin therapy if they have to go on insulin. We want to try to modify and take care of all of their diabetic needs, or gestational diabetic needs, with diet. In gestational diabetes is kind of a type 3. It's insulin antagonism by the placental hormones, placental lactogen. Human placental lactogen, progesterone, cortisol, and prolactin levels leads to increased blood glucose levels. So these hormones peak at about 26 weeks gestation, and this is called the diabetogenic effect of pregnancy. So during the second and third trimesters, pregnancy exerts that diabetogenic effect that ensures the abundant supply of glucose for the fetus. So pregnant women, no matter pregestational or gestational, will have an increased insulin resistance during the second and third trimesters. That's why we screen them somewhere between the 24th to the 28th week. According to your text, it's around the 26th week that peaks. And I know that some doctors' offices, it seems to do the glucose tolerance test at 24 weeks, but I really don't care what doctors' offices say. What I care about for testing purposes is that you know what your textbook says. Blood glucose control is with diet. That is the goal. In all caps, you see that. We want to achieve and maintain normal blood glucose levels, euglycemia at less than 120. We want to provide adequate energy to give them adequate energy to gain weight and prevent ketosis. We want to talk to the mom about nutrients for mother and the fetus while maintaining that tight glycemic control. Assess medical, social, and food history. She might need to see a dietitian. We might have to have her go see a dietitian so that she can pick some choices that are healthier for her and the fetus. ADA recommends maintaining fasting glucose levels below 95, postprandial levels below 140 at 1 hour, and below 120. Now let's talk about some metabolic disorders. So we're looking at thyroid disorders such as hyperthyroid and hypothyroidism. So we also look at maternal phenylketonuria. Um, we assess this, of course, when our neonates are born. We do PKUs on them. We have to check this on mom. Does she have it? This is a really big thing. Key to prevention is identification of women with the disorder in their reproductive years. They have to be advised against breastfeeding. There's dietary exclusions that include the protein and wheat products. Now let's talk about cardiovascular disorders. Major cardiovascular changes occur during pregnancy that affect women with a cardiac disease. And the reason why is because they have increased intravascular volume, decreased systemic vascular resistance, cardiac output changes during labor and birth, intravascular volume changes that occur just after childbirth. So we look at the cardiovascular disease classification, class 1, class 2, class 3, and class 4. We'll determine at 3 months and again at 7 and 8 months gestation. Well, here's the thing. Cardiovascular disorders put moms at an increased incidence of miscarriage. Preterm labor and birth are more prevalent. They have IUGR, which is very common. The incidence of congenital heart lesions is also increased in children of mothers with congenital heart disease. It occurs mainly because of increased circulatory volume. So what should you look for? What should you assess? Looking at the cyanosis of the lips and nail beds, crackles at the base of the lungs. We want to look for orthopnea if they're having some increasing dyspnea. A client who starts complaining of dyspnea on exertion is likely going into some left-sided heart failure. I'm not saying all pregnant clients. I'm talking about cardiovascular clients. I'm talking about those with problems with the heart. It is important for you to know that pregnancy is a significant stressor on the cardiac system. Women who enter pregnancy with a history of cardiac problems already must be monitored very carefully, not only by the OB doctor, but also a cardiologist. You have to be vigilant. Again, look at your patient. You've got to look at your patient. You have to assess them. You have to listen to them. You have to look at them. You have to figure out if there's something more going on. Don't discount these things that they're telling you. We have to be very vigilant with our cardiac patients to make sure that they're not going into cardiac failure. We have to look at their respiratory and systemic congestion. Congenital heart disease that we might see in a clinical setting, atrial septal defect, ventricular septal defect, coarctation of the aorta, tetralogy of Fallot, some acquired mitral valve prolapse, mitral valve stenosis, and aortic stenosis. What if they've had a previous myocardial infarction? Other cardiac diseases and conditions that might be present: persistent pulmonary hypertension, peripartum cardiomyopathy, infective endocarditis, Ensminger syndrome, and Marfan syndrome. I have my husband's ex-wife who had her last child. I can remember seeing her, I think she was probably about 28 or 30 weeks along when we took my stepchildren home one summer, and talking to her. She was just... she was swollen all over, and I thought then, man, but I didn't see her all the time. They lived in Texas. I wonder how her physician's following up with her. I just didn't feel close enough to, make that, hey, are you... I did make a comment about her edema, and I knew that she was still smoking, so those were some concerns, little red flags. And then postpartally, she ended up with cardiomyopathy and ended up in ICU. It was a very quick trip we made all the way down to Colorado City, Texas, to take care of not only my stepchildren but her newborn child, because she wasn't married and didn't have anybody to do so. The sisters were at the hospital for her. these are some of the things that we have to look at. And y'all, when we're talking about the high risk pregnancy and talking about the older client, she was an older client. She was in her late 30s when she got pregnant, maybe close to 40 when she got pregnant with this last child of hers. So we were dealing with some hypertension pre-gestationally that she was going through, plus that she was a smoker, and so she has a big history of heart disease. So we have to not only just assess these clients in the gestational period when they're pregnant, but when you go into the postpartum setting, you need to be very vigilant. A lot of people think, well, I'm just going in assessing as a normal postpartum patient, but they can become a cardiac patient in a snap. Heart transplantation. There's an increasing number of heart recipients that are successfully completing pregnancies. Before conception, women must be assessed for quality of ventricular function and potential rejection of the transplant. They highly, highly encourage that conception be postponed for 1 year after transplant. Vaginal birth is preferred, but transplant recipients have increased rates of C-births. So what are we going to do? We need to make sure we do a thorough antepartum assessment. Our plan of care and implementation. Therapy is going to be focused on minimizing stress on the heart. We want to look at signs and symptoms of cardiac decompensation. What is that? Dyspnea, crackles, irregular and weak pulse, so we might have to put them on bed rest. We might have to do some additional nutritional counseling. They might need additional cardiac medications, and of course I think we'll be following up with their cardiologist as well. These are just things that you need to look at. There's also anticoagulant therapy that these patients may need. Intrapartum care is going to be focused on promoting cardiac function and prophylactic antibiotics. Postpartally, we're still going to monitor for cardiac decompensation. We have to document the pre-pregnancy status, limitations. She's probably going to require weekly visits through the pregnancy. We have to observe and report for any hypertension, diaphoresis, pallor, syncope, fever, look at her capillary refill, jugular distension, edema, pulmonary or body-wise, changes in her activity level, factors that increase stress on the heart. If her activity level has decreased because she has increased dyspnea on exertion, that's a warning sign for us. Here are some common nursing diagnoses. Other medical disorders in pregnancy. Anemia is the most common disorder of pregnancy. Not all pregnant women are going to need additional iron with their prenatal vitamins. Many times the prenatal vitamins are enough. It is all that they need. However, there are some women that will require. This is again where you have to look at your patient. You have to know what they have going on. Are they a cardiac patient? Is it essential that we're adding iron to their diet so that we keep them built up? Is there something that's going on with them? Do they have folic deficiency anemia? What about sickle cell? What about thalassemia? These are the things that we're having to look at with our pregnant client. And though we might not want to add additional iron to them, it may not be what your book says to do. Again, you have to look at each individual and each client and know and assess them and find out what's going on lab-wise and etc. This is anemia occurs with anemia that occurs with any other complications such as PIH can also result in CHF. With anemic, even normal blood cells at delivery is poorly tolerated. So we see some increased blood transfusions. That's why we monitor what their labs are. We look at them. Sickle cell clients who are pregnant may be at increased risk for crisis related to dehydration and hypoxia or transfusions. We have to be diligent and monitor these clients. We have to look at them closely. We have to monitor for the development of UTIs or preeclampsia. Infections are usually treated pretty aggressively with these clients. We're going to do frequent ultrasounds to check fetal well-being. Vaso-occlusive crises are precipitated by hypoxia in pregnant clients as well as non-pregnant sickle cell clients. Sickle cell anemia, as y'all know, is an autosomal recessive disease. So when hemoglobin of sickle cell clients becomes misshapen, the clients become hypoxic, they become acidotic or dehydrated. Y'all, this is a very, very serious state for the pregnant woman and the fetus. These clients have to be cared for immediately with IV fluids. We have to reverse the hypoxia and acidosis. Now, with a sickle cell client, we also don't want to supplement them with iron. We don't want to overload them. But one of the priority interventions for when they're having starting to go into a crisis is going to administer IV fluids. Now, I know that we have been taught that we need to look at ABCs and we need to put oxygen on them. But if you don't get the IV fluids going on your sickle cell client, think about what happens to the fetal environment. Because the hemoglobin of the sickle cells become misshapen, and so what happens? What do you think happens to the perfusion? So this is why it's essential that priority-wise we get some IV fluids on them. I'm not going to go through some of the next couple of slides. I've covered these extensively in another lecture, but these are part of the high-risk lectures when we're talking about iron deficiency, when we're talking about pica. So I'm going to skip past these slides, but just know that it is testable material. It is part of these pulmonary disorders. We're talking about asthma. Exacerbations and remissions are a real possibility. We got hyperactive airways, effective pregnancies. It's unpredictable. They're also at increased risk for postpartum hemorrhage. It's not only fatal and serious rather to mom, but it's serious to the fetus as well. What happens when the anatomy and enlarging uterus happens? They have increased progesterone that creates changes in their lung capacity. Mom has trouble breathing, so the fetus has trouble getting the oxygen. She needs to be aggressively managed because the advantages far outweigh the risk with the medical management. In a cystic fibrosis client, infants and mothers with cystic fibrosis will be carriers of the gene. With severe disease, pregnancy is often complicated with chronic hypoxia and frequent pulmonary infections. So there is problems with the respiratory and digestive systems that we have to monitor these clients pretty closely as well. You have some integumentary disorders that are induced by pregnancy. You have some other skin problems that we can also be aggravated by pregnancy. These, not that these are not bad things. Some of these do put the patient at high risk. But I want to get to, for time's sake, and y'all being able to listen to these slides without it taking you a long time, I'm going to get to epilepsy on the next slide. A big safety alert. Tegretol and Depakote should be avoided if possible during pregnancy. This is especially during the first trimester. What happens during the first trimester? We have organogenesis going on. Why do we need to avoid it? It's because it is associated with neural tube defects in the fetus. Anti-epileptic drugs are also associated with other congenital anomalies such as cleft lip or palate, congenital heart disease, urogenital defects, and neural tube defects. Failure to take medications is a common factor. They need to receive preconceptual counseling. And of course, they're at risk for congenital anomalies if the mother is taking the anticonvulsants. I hope that this mother is seeking counsel from a physician before she chooses to go about carrying a pregnancy because of all the risk for her as well as the fetus. When you have multiple sclerosis, that these clients are probably going to have bed rest and steroids used to treat acute exacerbations. And then Bell's palsy can happen. They'll get acute facial paralysis. We know that that's completely. Autoimmune disorders often occur during pregnancy, such as systemic lupus, antiphospholipid syndrome, rheumatoid arthritis, and myasthenia gravis. Common symptoms, they're going to have myalgias, fatigue, weight change, and fever. Prenatal care focuses on monitoring complications related to hypertension, proteinuria, and IUGR. We want to monitor that fetus closely with frequent ultrasounds, encourage fetal movement counts, weekly to twice weekly NSTs. We're going to look at amniotic fluid assessment and biophysical profiles. Women can develop exacerbations from lupus during delivery. It is recommended these women limit the amount of pregnancies that they have due to the overwhelming amount of monitoring for mom and fetus prenatally, during delivery, and during the postpartum period. Myasthenia gravis, one of the biggest things you need to know about this is there's a big safety alert with it. Magnesium sulfate must not be administered to women with MG because it inhibits the release of acetylcholine and can trigger a myasthenia crisis. So substance abuse, we still see it. It happens. They have dual diagnosis, substance abuse plus some other psychiatric disorder is very, very common. It has damaging effects to the fetus that are well documented. What do we have to do for the mom? We can't accept her promises, can we? Do you think her promises will be valid that I'm going to stop abusing? We need to do our best to support. Why do we want to support? Because there could be a major barrier there to treatment if we don't. Women are going to fear losing custody of the child and criminal prosecution. Less than 10% of pregnant women receive treatment. Substance abuse treatment programs do not address issues affecting the pregnant woman, and there's long waiting lists and lack of health insurance that present barriers to treatment as well. Your attitude can also be a barrier to treatment. So when you're caring for her, make sure that you care about your patient. I know that sounds just caring, but just I'm not saying you have to understand what she's going through. I'm just asking you to empathize and understand that she is a human and she deserves just as much care, love, and respect as the next person. She's made some bad choices. We have to do the drug testing, though. We have to start screening for substance abuse. We want to try initiating her joining the methadone maintenance program, if at all possible. We have to see what we can do to support her and get her the care that she needs so that the fetus can have the care it needs. If she's going to continue to abuse, which we see it, breastfeeding is definitely contraindicated in women who continually use amphetamines, alcohol, cocaine, heroin, or marijuana. Substance abusers are difficult to care for, particularly during intrapartum and postpartum periods. Substance abuse is an illness, though. Women deserve to be treated with patient kindness, consistency, and firmness. Before discharge, we're going to check out the home situation. We might have to get case management and social services involved to look and send someone out to that home to find out what it is like there. Need someone available to meet the infant needs if the mother is unable. Family members or friends should become actively involved with the mother before discharge. And if the infant's well-being is questionable, a case can be referred to Child Protective Services. Thank you. That is the end of my presentation.